Yes, it's fine, Doc.
Can I carry on?
Yes.
Yes, we can all see it. Thanks, Doc.
All right. Apologies about that. Yeah. All right. So as I said, that the purpose of the talk is that all of us should confidently interpret the UNE by the end of this talk, and there will be a bit of exercises that we'll do at the end of the talk. So the definitions is basically we've got what we call acute kidney injury, and what is important about it is that it is a sudden temporary reduction in kidney function, and it's reversible. Basically, you're going to get an increase in serum creatine by 50% within 7 days. Or the other definition from KDIGO, they say it's an increase in serum creatine by 0.3 milligram per deciliter within 2 days, or a patient has got oliguria. So the time frame is quite important. With chronic kidney disease, the GFR has to be less than 60 for a period of over 3 months. And it's a reduced kidney function over a period of time. It's irreversible, it's chronic, it's been happening over some time. And then we've got what we call end-stage renal disease, which the definition is a GFR of less than 15, and it's total and permanent kidney failure. And then there's also one aspect that they mention, which is acute kidney disease. And there you get a GFR of less than 60 for less than 3 months, or a decrease in GFR by more than 35%, or an increase in serum creatine by more than 50% for less than 3 months. We hardly ever use the term the acute kidney disease, but you need to know the difference between the acute kidney injury and the chronic kidney disease. And sometimes we've got what we refer as AKI on CKD, or acute on chronic kidney disease. Just to recap, the function of the kidney is mainly for fluid and electrolyte regulation, for blood pressure control, and that we use the renin-angiotensin aldosterone system. And then we've got the acid-base homeostasis. We have also, it removes toxins, accumulation of your urea, the free radicals, drugs, and hormones, for calcium phosphate homeostasis, and also for erythropoietin production. Acute kidney injury, the definition, we have classifications, 3 classifications that can be used. We've got the rifle classification, and basically it tells you about the risk, the injury, failure, loss, and end-stage kidney disease. And I will show you a conceptual framework thereof. And then we've got also AKI network classification and the KDIGO classification, which basically mentions 3 stages, and we will not discuss it. I will not go into that discussion for this presentation. The key elements of KDIGO AKI classification is you'll have an increase in serum creatine by more than 26.5 micromoles per liter within 48 hours. So basically, I'm going back to the definition that I spoke to earlier. It's just the difference of the units. Or it can be an increase in serum creatine by more than 1.5 times the best baseline within 7 days. So basically, you'll get more than 50% increase in your serum creatinine and within 7 days. Or you get oliguria, which is a decrease in your urine output, and it will be less than 0.5 mils per kilogram per hour for 6 hours. The causes and classification of acute kidney injury. This is what we used to call renal failure. All right, so you've got your pre-renal, your renal, and the post-renal. The pre-renal, basically, the causes are still the same. That's where you get your volume depletion. It could be from hemorrhaging or from cardiac problems. When you've got dilated cardiomyopathy with low cardiac output states. Sepsis can cause that, liver cirrhosis as well. And then coming to your intrinsic renal disease, they are divided into different components. You've got your vascular causes where you can get your vasculitis, your thrombotic microangiopathies and hypertensive emergencies. And then you get your glomerulonephritis, acute GN, your acute tubulointerstitial nephropathy, and then you've got your ATN as well, and then you divide it into ischemic and nephrotoxic. And the nephrotoxic, it can be endogenous or exogenous, of which the endogenous will be your rhabdomyolysis, for instance, okay, your myelomaccus. And your exogenous will be your nephrotoxic drugs, including your contrast agent, which I'll talk about it towards the end of my talk. The post-renal, it's outside the kidney, is obstruction. It will be your bladder outlet obstruction or your ureteral obstruction. So anything that happens post-renal is referred to the urologist. This is, apologies for this slide, it didn't come out as clearly, but that is the continuum framework of your kidney injury. So your kidney starts off as normal, and then after that you get your high risk, and then you get the damage, and then your GFR goes down. And during that period, there are biomarkers that can be used in acute kidney injury. I'm not going to go into that in this presentation. And there is reversibility as well, you know, where you see the biomarkers and the clinical injury happening. If it's left too long, like if the patient, there's continuous exposure, then let's say, for instance, to a nephrotoxic drug like tenofovir, then subsequently you're going to get your reduction in the GFR, kidney failure, and death. Now, what are the risk factors of acute kidney injury? You've got the increased age. If the patient has had a pre-existing chronic kidney disease where there's a high serum creatinine and a low GFR or proteinuria. Diabetes mellitus, especially with diabetic nephropathy. Surgery is another risk factor, especially when it's compounded by hypovolemia and sepsis. Volume depletion and drugs, for instance, your NSAIDs, your IV contrast, and your antimicrobials, especially your aminoglycosides. And especially when the levels are not being checked up, you know, your trough levels for your vancomycins and your gentamicins. Now, principles of management of acute kidney injury. It is important to recognize the changes in the urine output or the kidney function timeously, and then identify and reverse the underlying cause. Next will be correction of the pre-renal states and maintenance of your hemodynamic stability. And then avoidance of nephrotoxic agents, and if possible, you adjust your medication doses to the level of kidney function. Also, provision of your supportive care, including nutrition and medical interventions to maintain your fluid, electrolyte and acid-base balance, and initiation of your renal replacement therapy where it's needed. Now, coming to your chronic kidney disease, we have common causes, diabetes being the number one, followed by hypertension, your glomerulonephritis, for instance, your systemic lupus erythematosus, apologies, and then your HIV and drugs such as your tenofovir and your gentamicin, as I mentioned earlier, and then your obstructive uropathies. Signs and symptoms of your kidney problems, especially your chronic kidney disease, will be coming from the retention of products that are usually excreted by the kidney. Okay, your nitrogenous waste, and then buildup of your hormones, drugs, etc., which are metabolized in the kidney. Other symptoms will be from deficiency of the products which are synthesized in the kidney, like your erythropoietin, which will give you the anemia, the impaired fluid and electrolyte handling, and the effects of the uremia. These are, I saw this slide and I liked it. Because it's from clinics. It's symptoms of your chronic kidney disease. There'll be less urine production, swelling. Basically, it's being fluid overloaded with shortness of breath and swelling of the entire body. Your appetite loss, nausea and vomiting, and high blood pressure, and feeling cold and tired. This is the classification of chronic kidney disease, and it's by the National Kidney Foundation, and it's Kidney Disease Outcome Quality Initiative. If you look at stage 1, it basically uses the glomerular filtration rate, and it's measured in mL per minute per 1.73 meters squared. If your GFR is more than 90, it's considered to be a normal kidney. And then stage 2 will be if it's 60 to 89. If you use labs like the NHLS, everything above 60 is considered to be normal. And then you come to your stage 3, which will be divided into 3A and 3B. And that's 3A will be when your GFR is 45 to 59, and your 3B will be when it's 30 to 44. Then you come to your stage 4, and your GFR will be 50 to 29. And lastly, you've got stage 5, which is less than 15, and that is end stage and approaching kidney failure, and the patient, we need to start preparing for dialysis. The laboratory measures that we use is the UNE. You'll get your urea and creatinine being elevated. The patient will have metabolic acidosis. Hyperkalemia will be one of the things. Anemia from erythropoietin deficiency. Then you get your hypocalcemia and your hyperphosphatemia, as well as your high parathyroid hormone. And I'll just explain it briefly in the next slide. So you've got a normal kidney on the left, and going towards the right, you see with renal failure, there's reduction of the number of nephrons. And the phosphate, instead of being excreted, it builds up in the body, and you get your hyperphosphatemia. And then when you look at the proximal tubules, you'll see that 1.25 dihydroxyvitamin D, the levels are going to be low because the kidney is non-functional. And therefore, less calcium is absorbed in the GIT, and it gives you hypocalcemia, all right? Then with the hypocalcemia, you see the calcium sensing receptors are being stimulated, which will cause a decrease in the degradation of the PTH. And at the same time, with your hyperphosphatemia, it will cause an increase in proliferation in the parathyroid cell, and you get increased risks of your parathyroid hormone, and that's how you get your hyperparathyroidism. And let me also say that this change, you normally see it around CKD stage 4 and up to stage 5. In other patients, you may see it in stage 3B. The complications of hyperparathyroidism, we've got what we call renal bone disease or osteodystrophy. You can get your osteitis fibrosa cystica from high PTH, and it's basically because of the high phosphate. And the low calcium will lead to high bone turnover with a decrease in bone strength and fractures. Then the other one will be your osteomalacia from the low vitamin D, and also from the aluminum accumulation and metabolic acidosis. We no longer see much of the aluminum accumulation because of there's less exposure to it now. And then you can get what we call your adynamic bone disease. The etiology is unclear, but it's common in patients who are on peritoneal dialysis. So these are factors which influence the CKD risk progression. We've got the non-modifiable factors and the modifiable. And the non-modifiable is basically the underlying cause of the kidney disease and the race. Okay, and they say the progression is faster in Black patients. This is as per my Handbook of Oxford Dictionary. And the modifiable is your blood pressure, your level of the proteinuria, plus any of the following: exposure to nephrotoxic agents, your underlying disease activity, such as in lupus, your further renal insult or insults, hypovolemia or intercurrent illnesses, your dyslipidemia, hypophosphatemia, metabolic acidosis, anemia, and smoking, as well as glycemic control if the patient is diabetic. These are the therapies which are thought to be that can be used for intervention. And you look at there's proven benefit and there's preliminary evidence. Proven benefit is your ACE inhibitors. You've got your ARBs, angiotensin receptor antagonists, and mainly your blood pressure needs to be controlled. And the goal is between 120 and 140 millimeters of mercury for the systolic BP, and 80 and 90 for the diastolic BP, and also proteinuria reduction, which will be accomplished by the use of your ACE inhibitors. Those that still need preliminary evidence are your aldosterone antagonists, your renin inhibitors, things like your dietary measures, exercise, weight loss and obesity, smoking cessation, your glycemic control. Reduction of your hyperuricemia is also one of the important ones, because high uric acid has been shown to contribute quite significantly to hypertension. Now we've got what we call AKI on CKD. Remember what I said earlier? I said acute kidney injury is reversible, it's temporary, it's sudden, whereas chronic kidney disease is irreversible and it's over a prolonged period of time, and usually it's more than 3 months, and you get a significant reduction of your GFR. So the useful discriminators are: it is important that when your patient presents to you, if possible, get hold of the previous UNE that was done. All right, and at least it will give you an idea of how was the UNE, let's say 3 months or 6 months prior to the presentation. The other useful indicator is the ultrasound. With a long-standing renal disease, you get loss of renal parenchyma, which leads to a decrease in renal size. So if you've got a patient with hypertension, they will come with a small kidney size. It's characteristic of CKD and hypertensive patients. If your kidney size is normal sized, be suspicious of AKI. The other condition where you can see big size kidneys is diabetes, okay, diabetic nephropathy. If the patient has got both hypertension and diabetes, sometimes it may just lead to a normal sized, depending on which one is much more significant in that particular patient. The other findings is the laboratory findings. If a patient has got anemia, it will be suggestive of your chronic kidney disease. And if the calcium is low and your phosphate is high, it suggests as well your bone disease. Okay. All right, so the management, you need to treat the underlying condition. You control the risk factors for progression, tighten your glycemic control, the HbA1c of 6.5%, others books still say 7%. And then you tighten your blood pressure control, ACE inhibitors, especially where there is proteinuria or you can use your Rs, but be careful of the hyperkalemia. And then you control the modifiable risk factors, and you do adjust the medication which are handled by the kidney. Now, with the anemia, according to KDIGO, the recommended hemoglobin is 11 to 12. With other like NICE and the British one, they would say the HB, the recommendation is 10.5 to 11.5. So I think it depends on which one you want to use. And we use erythropoietin. The other important factor is that your anemia can be iron deficiency related, and that's what we see mostly in renal patients. And in hemodialysis patients, your ferritin it has to be more than 200, and in non-hemodialysis patient, it must be more than 100. Anything which is less than that, it's saying as well that the patient could be iron deficient. And then we also do use the saturation of more than 20%. If it's less, then you should consider giving your patient iron replacement in the form of your Ratuvin or Vinofer, or there are quite a lot on the market. And then prevent your hyperparathyroidism. How do you do that? Remember that I said that hyperparathyroidism will be coming from your high phosphate. So you will use the phosphate binders, okay? There are different kinds of phosphate binders. We've got the calcium-containing phosphate binders and non-calcium-containing phosphate binders. Unfortunately, the non-calcium-containing phosphate binders are quite costly. So in our setup, we've got what we call a BCAL, which has worked very well with our patients. And for the hypocalcemia, you will replace it with 1-alpha vitamin D. Electrolyte abnormalities such as your high potassium, which you often get with chronic kidney disease, is look at your dietary measures, look as well at the medication that the patient is using. If your patient is on ARBs or on ACE inhibitors or spironolactone, you may have to stop that medication. You may use as well kayexalate. Manage your volume status appropriately. If the patient is fluid overloaded, you need to restrict their fluids. And if your patient is already on dialysis as well, you need to make sure that the patient doesn't take quite a lot of fluids. Also, your dietary protein, you should restrict it to 0.6 to 0.8 grams per kilogram per day. What is the management of your end-stage renal disease? It's renal replacement therapy, all right, and it's in two forms. It's either with dialysis or kidney transplantation. We've got two modes of dialysis. We've got hemodialysis or peritoneal dialysis, and there is indications for each, and there are benefits as well towards there are benefits for each mode that you may use. I'm not gonna go deeper into that. Yes, all right. So what are the indications for your acute hemodialysis? You are in casualty or in the medical ward, and this is one thing that I always teach to our interns and our medical officers. That is, if your patient is fluid overloaded and they're unresponsive to diuretic therapy, or your patient has got a refractory hyperkalemia, that is, you keep on shifting the potassium, but it stays where it is. If the patient is anuric, and the definition of anuria is urine output of less than 100 mL per 24 hours, or if the patient is oliguria, that is urine output of less than 400 mL per 24 hours. If the patient has got your severe metabolic acidosis as well, unresponsive to sodium bicarbonate treatment, that would be another indication. If your patient is uremic and they've got other complications such as your encephalopathy with seizures, then that would be an indication to say, I need to intervene. I've just mentioned drug overdose. It's not part of what we are discussing today. If your patient, let's say, was on lithium and they took, there was lithium toxicity, that would be another indication to dialyze, otherwise you lose your patient. Or if the patient, overdosed with antifreeze. In the country, we don't have fomepizole, which is an antidote, so you will have to dialyze them. A brief note on contrast-induced nephropathy, because most of us, use it quite a lot and we send our patients for scan. So the definition is when your serum creatinine is a rise in your serum creatinine of 25% from the baseline, and it happens within 48 to 72 hours of contrast exposure, and there are no identifiable causes. The type of contrast agent, you would want to know whether your patient used the high osmolar or the low or isoosmolar. The pathogenesis, basically contrast, what it does is it's going to cause your renal vasoconstriction, which is mediated by your nitric oxide, your endothelin, your prostaglandins, and your adenosine. Nitric oxide is a vasodilator, endothelin is a vasoconstrictor, prostaglandin is a vasodilator. So there's basically going to be, all those mediators playing a role. Your direct tubular toxicity, okay, from your tubular obstruction, high viscosity, that is your contrast of the contrast agent. And then we've got risk factors for the contrast-induced nephropathy. You've got patient-related risk factors and disease-related risk factors. With your patient-related, if they are older, it's a problem. If they've got diabetes mellitus, especially with nephropathy, if they've got chronic kidney disease, congestive cardiac failure, and they've had renal transplantation. Disease-related will be if your patient has got anemia, the volume depleted, and exposure to nephrotoxic drugs, and they've got also hemodynamic instability. So those which are procedure related will be the type of contrast that you are using. Is it the high contrast volume with high osmolality and high tonicity? And also if you apply, if you give multiple administration within 72 hours, then your patient can come in with contrast-induced nephropathy. Treatment, the important thing is, can I prevent this? Is it necessary to expose your patient to contrast? Can it wait? The other prevention method is, are there other alternative imaging methods that you can use as opposed to just exposing your patient to contrast? And then can you use the lowest dose of contrast instead of your high osmolality? Can you use the iso or low osmolar contrast? Also, can you avoid repetitive studies within 72 hours? Is it necessary for the patient to go for the CT abdomen or whatever if the first one was not helpful? Avoid volume depletion and avoid nephrotoxic drugs. So fluids, okay, if your patient is going for contrast, for a contrast procedure, what you can do is you can prehydrate your patient, give your patient fluids, sufficient fluids, and then there's a drug that is called N-acetylcysteine, commonly known as Pavolex, the one that we use for paracetamol overdose. They say you can use 600 milligrams BD per oz, and you give it on the day of the contrast and the following day. So it's only 4 doses. You give it for 2 days. And it's antioxidant. It's got antioxidant properties, vasodilatory properties, but there are no recommendations regarding its benefits from clinical trials. It's got low cost, no adverse events, and a potential benefit effect. Other agents, which we're still waiting for trials. Maybe there are some trials which have come through. The use of theophylline or even statins. Dialysis should not be used prophylactically. I repeat, dialysis should not be used prophylactically. Now, this is the exercises. So I'm going to do 3 exercises with you. And then I'm going to ask somebody from the floor. One person from the floor can do the next 3 exercises. All right. Or yeah. So here we've got a patient. This is Mr. T, 42-year-old. He was admitted being COVID positive, COVID-19 PCR positive. He was newly diagnosed retroviral disease. If you look at your full blood count, on admission on the 20th of November 2021, you can see that he was neutropenic. The white cell count was low, and also the platelets were down. All right. And then the CRP was also a bit on the high side, but if you look at the renal function, you can see that the urea was 17.9 and the creatinine was 266. And the GFR was mentioned to be 24. And then you go now to the 14th of January. This is about 6 weeks later or so. And you can see that the white cell count has completely recovered. He's got a white cell count of 4.65. The platelets are on their way up as well. And the urea has normalized, the creatinine has normalized, and the GFR is 86. So this is a classic example of acute kidney injury secondary to sepsis. The second patient is Mrs. M. Okay. So this one is going from the right to the left. So Mrs. M is a 68-year-old female with anemia and cellulitis of the right leg. And if you look at the extreme right, you'll see that the hemoglobin was 4.4. The urea and creatinine were high. He had a urea of 44.4 and the creatinine of 580, and the GFR at the time is 6. She was transfused 2 units and the HB went up to 6.2, and she was offered dialysis as well, and she was transfused during dialysis. And the HB went up to 8. Also, the MCV is within its normal. Okay, so it's a normochromic anemia, normochromic normocytic anemia. And then look at the UNE when the HB is 8. You see the improvement that now the urea is 26 and the creatinine is 265 with a GFR of 15. Okay, the CRP had gone up, and as you look as well at the following slides, you'll see that the CRP and the PCT were going up. This is basically now when, this was following debridement as well of the cellulitis, and this thing, it became better later on. So we started dialysis with the urea with the GFR of 6, and you can see the subsequent improvement. So she was dialyzed then, the GFR went up to 15. The following day, before dialysis, it was checked, it dropped again, dialysis was offered, the GFR went up to 20. So this is the pattern that normally a patient with CKD has, or end-stage kidney disease. All right, so surprisingly, you look at the potassium, it's more on the lowish side. And this is a classical case of, patients with primary hyperaldosteronism. We're still waiting for the renin and aldosterone levels. Okay, so the calcium, this is the same patient. And if you look at the calcium and the phosphate, you can see that the calcium is low and the phosphate is high. All right, the normal, there's the normal range on your left-hand side. Patient number 3 is Miss P. She's a 60-year-old female, newly diagnosed RVD with also underlying hypertension. All right. You look at the urea and the creatinine. So this is in 2021, when I mentioned the period that is got to be more than 3 months with a decrease in your GFR. You can see that her GFR on the 9th of January 2021, it was normal, it was 106. And in June, it was 79. So those are normal. All right. And then I saw her on the 6th of December. So this is 6 months later, and you can see the GFR has plummeted down to 5. Okay. And the urea is 14 with your creatinine of 697. We repeated that the following, on the 22nd, it was still low. All right. So this is the same patient. And you can see the hemoglobin also is, the hemoglobin is on the low side. And the GFR is persistently around, okay, it was 5 and then it went up to 18. So remember that the GFR of more than 15, now we say it's CKD 4, all right? So after a few days, okay, we held dialysis after the GFR of 18, checked it again, on the 3rd of February, it had gone down again to 15, all right? So at the moment, this is where we are. She's off dialysis and the GFR seems to be on its upward trend. Okay, so could this be, from the acute kidney, you've got the underlying chronic kidney disease with a component of the acute kidney injury added to the problem, all right? So the next, apologies, I tried to do Excel and it excelled me. So if you look at this patient, now I'm going to ask for anyone from the floor to tell me what is happening. This is a 37-year-old lady. She rocked up in my rooms and said, "Doctor, I was admitted at a hospital and they told me that I've got kidney problems. Please, they discharged me. I don't know what is happening. Nobody spoke to me, but help me. Do I have kidney problems?" Can anybody tell us what is happening? Any takers? Am I allowed to ask questions?
Yeah, sure. I'm sure there will be. Oh, there's someone, Ashraf, Dr. Lambert has raised a hand.
Mhm.
Dr. Lambert, you can unmute yourself. Ashraf? If you can unmute yourself there.
Doc, can I take a swipe at it?
Yes.
Okay, sure.
Yes. Can you hear
Yeah,
me?
yeah,
Okay. The possibility of a nephrotoxic drug here.
Uh-huh.
The possibility that you've given us some treatment and a drug
Mhm.
reaction.
Yes. Very good. Which drug?
But depending on the conditions you went in for,
Okay, I said
Yeah.
she's reactive. There's the CD4 count.
Oh, okay.
All right.
so
Yeah,
it could be
Dr.
tenofovir.
Consistency
Tenofovir.
Yes. Okay. So this is a clear case of tenofovir toxicity, which was reversible. All right. You can see that when I saw her on the 8th of March, the GFR was back to normal. Okay, to 91. All right. So the patient was subsequently changed to a Abacavir regimen. The next patient is a 59-year-old male patient with type 2 diabetes, hypertension, and increase in BMI, was admitted with congestive cardiac failure. And the current medication is Lasix 40, metformin 850 BD, and Pharmapress 20 milligrams daily. Comment.
I said, Dr. Ashraf is hand up. Okay, you can go ahead, Doc. You can unmute yourself.
Can you hear me now?
Yeah, we can hear you.
Okay. I suspect metformin 850 milligram could be a cause.
All right. Where?
Renotoxicity with the metformin.
All right. Okay, fine. Metformin would be part of it, but when would you not use metformin? Is when your GFR is less
When the
than,
GFR is dropped,
yes,
say below
all right.
50, below 60.
No, you don't use metformin when it's less than 30. All right.
Okay. All right.
All right. All right. Yeah. So basically, the patient has got a chronic problem. He's type 2 diabetic and he's hypertensive, and you can see that the GFR has slowly been declining, okay, from April 2020. And this is a case where the patient has not been well controlled. We don't know what the HbA1c has been throughout the 3 occasions, but you can see as well the potassium is climbing up, okay. When we saw the patient, it was 5.7. So that's the hyperkalemia from your chronic kidney disease. And also the HB is going down, and you can see as well your calcium, it's going down. So you are getting hypocalcemia with your hyperphosphatemia. The last patient is 70-year-old, a type 2 diabetic, who was admitted in DKA, followed by persistent vomiting and urinary tract infection. Comment? This is over a period of 1 week. I think, Doctor, it will only be you, and I've got a small booklet that I have written when I was still at Ratong Hospital, and I will give you a copy for free. You want to make just the last one, and then I can hand over to Dr. Bila.
Yes, Dr. Lambert. Yeah, it looks like he's. Are you taking this one, Dr. Lambert?
Possibility of some type of an infection. When I'm looking at the CRP level, it started at a high level and it was dropping.
Yeah.
So some form of sepsis.
Yeah, you are right, but talk about the UNE. This is just in 1 week, eh?
Acute AKI.
AKI on. This is a typical case of AKI on CKD, all right?
On CKD,
All right,
okay.
yeah, there
Combination.
may be an element of CKD. I mean, look at the remaining GFR. It shows that the patient is about stage 3A, but once, because look at this, your CRP was high, all right? And remember as well, the patient was
Yes,
volume
107,
treated.
it went to 40.
And as they replaced the fluids and treated the urinary tract infection, the CRP went down and the creatinine, the urea and the creatine as well started going down with the GFR improving. So you can now say the patient at least is stage 3A. That concludes my discussion. These are my references and I'll be happy to take questions. Thank you.
Oh, thanks a lot, Dr. Moabi. Thanks a lot, colleagues. And Dr. Ashraf Lambert, you can send us your details at clinics at webinars. Webinars at clinics that we can then where you registered for the webinar, so we can then arrange for you to get the book that you have won for attending this webinar and also giving some good answers to the questions that were posed during this discussion. Okay, thanks a lot, Dr. We then open for conversation. Any questions, Dr. Makhotso? I see you say sharp. You've got a question, Dr. Makhotso? Or is it Dr. Lambert? It's under Dr. Makhotso. Any questions? Anyone who's got a question that you want to ask Dr. Moabi or comment?
May I ask a question around the dietary measures that should be brought into place, in particular when we're looking at the protein restriction between 0.6 to 0.8 per kilograms? I just want to find out, is there any specific type of protein that you are talking about? Could be, is it meat or is it associated with other sources of protein, such as vegetable proteins?
Okay, protein is mainly from meat, and the dietary measures, you know, your patient is proteinuric at that time, and you don't want to add more protein. So we normally say a low protein diet and ask the dietitians to have a look at it. So as I had earlier stated, that is supposed to be 0.6 to 0.8 grams per kilogram per day. So it's mainly a low protein diet.
The question was any specifics around red meat or vegetable diet?
Well, vegetables don't have protein. The protein is mainly from the meat. So I mean, you can swap your protein portion. For instance, instead of giving red meat, you can use beans and legumes. I mean, those are good dietary replacements.
Thank you.
Dr. Lipota, you can unmute yourself and ask your question.
Dr. Miller, can I just request that you enable the chat so that we can put the reference in the meantime minutes?
Can I do what?
Enable the chat. It is disabled at the moment.
Who's disabled? Or the chat?
Mm-hmm.
Yeah, the chat is disabled so that people can pose questions or make comments.
Oh, I see. Okay.
Yeah.
Or is it me who's supposed to do that? I didn't know that I'm in control for now.
Okay.
Where do I do it? Okay, go ahead, Dr. Lipota. I think he's unmuted himself.
But it's still disabled.
Is it?
Yes.
His name is unmuted.
Okay.
He can speak. Dr. Apota, you're not muted. You can speak.
Yes, I was saying, I didn't get your last remarks with any people who are attendees. Where should they send their?
Oh, okay. No, the webinars at clinics.co.za.
We should send our credentials there.
No. When you log in, you log in with the details, and automatically we'll send this information to the HPCSA, and you'll get your CPD points. I was talking in particular to Dr. Lambert because he has won himself a book. So I was asking that he should give us his Is the chat disabled? People can't.
Yes, the chat box. The one where you write messages, that one is disabled.
Is it disabled? Can you enable it? I think just right here. You can write your chat just pose a question. Yeah. Okay, thanks, Dr. Report. Anybody else has got a question for Dr. Moabi? Anyone?
The chat is disabled.
The chat is disabled. Hey, Kamo, can you please enable the chat? It looks like that's how I was wondering why people can't pose questions. Hi, Kamo. Okay.
Hi, Dr. Bila. It's enabled.
It's enabled. Please, yeah. So please, colleagues, you can pose your questions on the chat box there. If there's any question, please, Dr. Bob, go ahead. Your hand is still up, and Dr. Makhotso.
Yes. I'm interested in finding out about the use of ACE inhibitors or the ARBs. Would you use them in patients with without hypertension for reducing the proteinuria?
Yes, you may use it to reduce the proteinuria, but at the same time you need to be aware of the complication of hyperkalemia, which is often missed.
Okay. What doses would you recommend for someone who is normotensive?
Well, it will depend on which one you use. There are just, you've got your Pharmapress, and you've got your Captopril. I haven't seen it in a while. They're just different ones. And,
yes.
Use them and then see how your patient responds to what you have given, all right, in terms of the proteinuria. So I cannot say it's a fixed thing, it's that.
Okay, thanks, Dr. Moabi. Dr. Makhotso.
Dr. Moabi, thank you very much. A wonderful presentation. My question is with regards to the elderly. Could you kindly share your thoughts on, antihypertensives in the very elderly? I'm talking the 80-year-olds, the 90-year-olds who are still on antihypertensives, but it appears like their blood pressure levels seems to be dropping because of obviously because of the endothelial that appears to be lagging, one, but two, the question that I'm also asking is the parameters that you used for renal changes applicable even in that age group? Because in any event, you find that, in the normal elderly, that the GFR tends to decrease. Would you still give the same classification even in the elderly? Thank you very much.
All right. In the elderly, it's another topic on its own. All right, because in the elderly now you're having a reduction in renal mass. Their way of handling the electrolytes, the way of the medication that you use, for instance, will be completely different. Depending on also the age of the patient. Okay, and things like diuretics, you wouldn't want to use them. Because of the side effects, unless, they are indicated in that course. There is just a big section on drugs and the elderly, and also kidney disease on the elderly, just like, kidney disease and pregnancy. So the elderly, in most cases, you'll see what is systolic hypertension, all right, and they respond very well to amlodipine, okay, your calcium channel blockers.
Okay, there's a question from Dr. Karashmet. Is there a place for Verahexal in CKD? Can you hear me? There's a question here.
Yeah.
From Dr. Karashmet. Is there a place for Verahexal in chronic kidney disease?
Verahexal is in chronic kidney disease. Most of the antihypertensives are used without any problems, There are drugs which you have to tailor. Verahexal is I'm just trying to, it's a calcium channel blocker, isn't it? Hello?
Yeah, that's the person who asked the question. I wouldn't know myself.
Yeah, I think it's one of the calcium channel blockers. I can't just remember very well, but the antihypertensives, we use them in chronic kidney disease without much problem. The entire aim is to control the blood pressure.
Can we, there's a number here, 9, if you can mute Gamu. Okay, you muted yourself, Dr. Moabi. Please unmute.
No, I'm not muted.
Oh, okay. Okay, go ahead. All right, yeah, that question, I did hear the answer that, yeah. There's another question here. Sorry, let me just find it. The use of muscle building products, e.g. creatinine, on the renal function. Any comment?
Can I ask Prof to answer that one? I saw Professor Variava is there on the chat group.
He's going to do the closing.
Oh, I see.
Yeah.
I'm not sure.
You're not sure about this one?
No, I'm not sure.
There's another question. I think I saw Dr. Nancy making a comment about the traditional medicines that is quite common in patients with HIV.
Well, with traditional medicines, we normally see what we call acute tubular necrosis, and those patients end up going into kidney failure because of the nephrotoxic property of the
well, there is, I suppose, a point where it also.
So about you, go ahead. Yeah, please, if you're not talking, please don't unmute yourself, please. Only unmute yourself when we are asked to do so.
Yeah. So what we see mostly with traditional healer medication or herbs is that, those patients come in with acute tubular necrosis and they end up being dialysis requiring. Some of them, they do reverse, others, they become chronic from that. It depends on the repeated insults and exposure.
Yeah, Dr. Lehman wants to know are you using cystatin C levels to monitor kidney function as well as creatinine, which is influenced by muscle mass?
Well, cystatin C, basically what is being used at the moment is you've got your CKD AP and your CKD MDRD to check for your GFR. So cystanin C is one of the good ones, but from where I'm working, we don't have access to that.
Okay, that's quite a number of people quite say thank you for good presentation and bring it down to a level. I think it's quite a number of people saying that. Just getting to the last. The patients with anemia, incidental finding of CKD, what's the recommended GFR on discharge? And also a patient with a history of angioedema, can you use ARBs? Yeah, I think that's ARBs, I thought, yeah. Any thoughts?
All right. Yeah. I mean, you cannot say what is the recommended GFR in somebody with anemia. I mean, anemia comes because of your chronic kidney disease, especially once the patient is end-stage kidney disease. You know, from CKD4, the lower part of it, to end-stage kidney disease. So it should be the other way around. I mean, your kidney is not functional, is not producing erythropoietin, therefore the anemia results from there. And that is the reason why we need to give the patient your erythropoietin. And then the second part was?
A patient with a history of angioedema, can we use, I'm not sure if it's ARB or ARVs?
Yes, okay, fine. So angioedema, yes, you can use, okay, your ACE inhibitors are working on your renin-angiotensin system. So basically they are blocking conversion of angiotensin 1 to angiotensin 2. Whereas your ARBs, which is your losartan and your valsartan, they will not give you, they work beyond your angiotensin 2, and they will not give you the side effects of the angioedema, as well as the persistent cough that you normally get with your ACE inhibitors.
Okay.
So I would say if your patient has got angioedema from the ACE inhibitors, you can change them, to your ARBs.
Okay, the next question is, which seems to be the last question from Dr. Bob again. In patients with HIV, what would you recommend to assess tubular damage? What did you recommend to assess tubular damage in patients with HIV?
Tubular damage is the question.
Yes.
is not that clear. I mean, if patients come in and they are reactive and with renal, is it just all patients with HIV you would assess for tubular damage? It's sort of like vague, and I don't actually understand what the question is. But any patients who come in with in kidney failure, number one, we want to know, are we dealing with a picture of an intrinsic renal disease, or are we dealing with a post-renal, which is mainly obstruction? Okay, so in the government setup, in the public hospitals, that's where you'd come from, because of the scarce resources to say, am I going to put this patient on chronic hemodialysis or not? All right, and if the problem is post-renal and it's an obstruction, you need to relieve the patient, to relieve that obstruction, and in some cases it may result in normal renal function. All right, that is why we always say you need to know what you are dealing with. Okay, if it's an obstruction from, for instance, a patient has got a big fibroid, then depending on how long the insult has been, when you remove when you do the myomectomy, the patient may recover, fully. So a renal ultrasound would be important in that case. If there is hydronephrosis, which is coming from the obstruction, that's what you'll be looking at. So with HIV, I wouldn't just screen everyone for tubular function. It's completely, yeah.
Okay, from Dr. Russell Holland, try to, does acute kidney injury predispose to chronic kidney disease?
With repeated insults, it may. All right. Let's say, for instance, your acute kidney injury is caused by exposure to gentamicin. You see, the patient came in with normal kidney function and went to the ward, was given gentamicin, the levels were not checked, and the kidney function was not assessed. With repeated insult, it may lead to that.
Okay, thank you very much. We're running out of time. I see there's still some more questions. Can you clarify the relationship of renal and cardiac? Maybe is they, how do you relate diseases?
Yeah, yes, there's what we call cardiorenal syndrome, and it's the whole pathogenic pathway, okay, for instance, if your patient has got a dilated cardiomyopathy, it's cardiac, they're in cardiac failure, they go into congestive cardiac failure. The kidney as well, gets an insult from that, especially if there's an element of sepsis. And there's entire classification on cardiorenal syndromes.
Getting new drugs that I don't know much about is gadolinium. Is it less nephrotoxic than iodine?
Gadolinium is it's what they use for MRI scans, etc. Yes, it is. It is as well. If I remember well, it is.
Less
nephrotoxic.
Yeah, it doesn't cause much kidney injury.
Okay. It can cause what we call NSF. It's a fibrosis, nephrogenic systemic fibrosis of the kidney. So yes, it does cause some damage. So, but I cannot say, contrast will cause more than, gadolinium also causes your nephrogenic systemic fibrosis.
Okay, last question is from Dr. Matlago. At what point do you treat anemia of renal disease in a patient on dialysis, and how do you monitor the response?
If your hemoglobin is less than 11, okay, fine. So there is that classification that I used, that I mentioned during my presentation, that the recommended hemoglobin as per KDIGO is an HB of between 11 and 12. And other associations would say 10.5 to 11.5. So anything which will be less than 10.5, you'd start treating with erythropoietin, and also you check if iron deficiency is not a component thereof.
Okay, I think this brings us to the end of the presentation. Just want to thank you. And I'm going to ask Professor Joe Vereva to do the closing remarks. He's a well-known physician and nephrologist himself of note, and I think he's got some remarks to make as he does the closing. Thank you very much. Prof.
Okay, thank you very much, Dr. Moabi, and good evening. I remember Dr. Moabi from her days as a registrar, and also when she assisted at Selby, and I always found her to be extremely thorough in everything she did. And she needs to be congratulated here because she's covered the topic of renal disease from the acute kidney injury to the chronic side of it. And I think that was an excellent overview. What was also really exciting was the cases that she put across to further illustrate what she had said previously. Now, chronic kidney disease is a serious problem. And the problem that we have in South Africa is that if we don't do things properly, they would in fact not be receiving even dialysis or treatment for end-stage renal failure. And in her talk itself, it was clear that once people have some kidney injury, one has to in fact try to prevent further progression of the kidney disease. So I think that the whole topic has been covered in a very excellent fashion. I just want to make one final sort of point, just in terms of new things on trying to prevent kidney or slow down the progression of kidney disease, because Dr. Moabi was correct that there is the cardiorenal syndrome. Now, in terms of the cardiorenal, or people that have both cardiac disease as well as renal disease, there's a new group of drugs that are now for diabetes, and they call the sodium glucose co-transporter 2 inhibitors, which seems to benefit both have cardioprotective effects as well as slow down the progression of kidney disease. And this is something that's very, very new. And I'm sure that this is something that we're going to hear a lot more. But the other point that I want to make is that there were lots of questions coming through, and that is a reflection on the presentation having an impact. So on behalf of all the listeners and also the clinics group, I think that we need to congratulate Dr. Moabi for an excellent presentation, and she, as well as the extent of her presentation, which was truly vast. So thank you very much, Dr. Moabi, and it's nice to listen to you. Well, I haven't seen you for a while, but I'm sure now that you're at clinics, I'll see you around again sometime. So thank you very much. And thank you very much, Dr. Biller, for keeping these talks going. You've done an excellent job every time you chair the meeting. So thank you very much.
Thanks.
Thanks, Prof. And thanks to Kamo from Clinics Marketing Unit. And colleagues, thank you. Next time we'll meet next week again. We'll be discussing NHI next Wednesday, Thursday. And Prof. Ferreira, thank you for being a wonderful support for clinics. I'll group as a member of the risk committee to keep us on our toes. And have a good evening, colleagues.
Thank you.